You are now live.
He's gonna write down. I have a copy of one right here.
Hey, welcome everybody. I'd like to call to order this meeting of the EMS Transition and Oversight Committee for April 7th, 2025. It's 4 o'clock in the afternoon. Are we gonna do a roll call of any kind? Okay, I'm Julie Hoyt. I'm here.
Anyways, I'm Mickey Barney, City Councilor.
Dave Grabowski, Fire Chief.
Frank Williams,
Maybe I'm the director of the emergency department, so I'm helpful.
Great.
Krishna Nambori, interim city manager.
Kyle Amsbury, Deputy Chief of Training EMS.
Jennifer Brinley, HR business partner.
Brian Burr, Assistant Fire Chief.
I'm Dennis Hughes, I'm a Salem reporter.
Matt Rosewood, President of the Fire Department.
Aaron George, EMS coordinator.
Emily Rodriguez, EMS analyst.
And Samuel Ruck, EMS analyst.
All right. Let's see, we're gonna start with a report on personnel. Who's gonna take that?
Yeah, we'll let Chief Amsbury, you want to talk about personnel onboarding? Where we're at?
Yeah, so we were, as you know, we're in the process of hiring 52 personnel, 22 paramedics and 30 EMTs. We currently have our last academy of paramedics today, started their first 2-week academy. And we have one more academy of EMTs that start on the 20th of April. The academies before that are all out doing the right time with their FTEP trainers. And so that process should be done for the paramedics about the end of May, and for the EMTs about mid-June. Everything seems to be going pretty well. The trainers are doing a good job. They're getting the most out of their shifts. And so everything seems to be on course with that.
We have additional staff that we're bringing on. There was the 52 paramedics, and then we have 8 per support staff. So in the room right now are our 2 most recent hires for they're going to be the data analysts. It's Emily Rodriguez and Samuel Ruck. They started with 110 applicants, and these 2 are the ones that were finalists that we brought on. They started with the orientation today, and then beyond that, we are going to hire an EMS trainer. We're going to hire a billing specialist, a staff assistant to kind of be a jack of all trades. And then we also bring on 2 buyers, 1 fire and one EMS buyer. That they will oversee all the inventory on the EMS side as well. And then in July, we should bring on the EMS, excuse me, Deputy Chief of EMS of Training, or Deputy Chief of EMS, which will be Kyle Amsbury. So he'll transition out of he's overseeing both training and EMS. He will transition to separate those 2.
Our EMS trainer posted today. So that's just out today.
Excuse me, so that was the 8, or is that in addition to that?
That is.
Okay, okay.
Yeah.
Okay,
So
just want to make sure.
yeah, no, it has been a long, grueling process. I
Yeah.
mean, the buyer position, we initially started with just 1 hire. We had 86 applicants.
Mhm.
And we narrowed that down we eventually hired 2 because we upgraded one staff assistant to a buyer. Because we just, after the staff looking at the overall engagement of what we were gonna have, it wasn't enough to have just 1 buyer. We needed 2.
Sure,
So,
sure, that
oh,
makes
yeah.
sense. That
but
makes
yeah,
sense.
it's been a long, arduous process, but it's been rewarding. So. And those
That's
buyers,
great.
the both buyers will start April 21st.
Okay,
So
okay. No, it's fantastic. You have so many applicants.
it's amazing.
And congratulations.
Thank you.
Do we have just a minute? You can each maybe just tell a sentence about your background? Is that
Sure.
okay? I think it
I
goes to
think
the
that'd be
quality of
great.
applicants, so please.
Sure. My name's Emily. My background is actually in criminal justice, criminology with a focus in data analytics. My passion is in conceptualizing data and being able to present that story. So that's where I'm here.
And your educational background, you get a master's?
Correct, yes, I have a master's from Portland State in criminal justice criminology, but with a focus in data analytics. So I spent about 2 years in Portland processing about 5 years worth of data, specifically from FBI information or reported information to process for resource allocation, deployments, really to identify patterns and trends and things over those 5-year period.
And a Salem local.
Correct, yes, born and
All right,
raised, yes.
awesome.
Yes.
Pretty awesome. All right, sir.
Yeah, and my background, my name is Samuel Ruck. My background initially, I got my undergrad in healthcare administration at Eastern Washington University. I was right before the pandemic, and so I was a little uncertain of what I was going to do to proceed, but I ended up getting a job up in Portland at Kashi Clinical Laboratories to do some of their claims analysis and kind of improve some of the samples and the way we were doing regulatory compliance. I ended up working on my master's towards data analytics. And just recently, 3 days ago, I got my certification in health data analytics. So I got that official certificate, but before that, I'd been working consulting for healthcare analytics, doing KPIs for provider utilization, metrics towards insurance reimbursement and all that kind of trend analysis. So I'm excited to use this skill set I've learned to this job because I feel like it has such an impact on the community and can have, a lot of success if we do it right.
Also from Salem.
Also born and raised, yeah.
Pretty awesome. Yeah.
Great.
The Georgia are actually out of the state. So it just, I mean, we really lucked out with these two. So, and these two will work hand in hand with our EMS coordinator, Darren George, and our physician supervisor, Dr. Clothier. So,
Especially in the data analytics.
oh, all data.
Welcome to the city.
I knew you would love that.
The city manager is also very data, well, she's.
You're data.
She called herself a data nerd.
I love that.
Me too.
But ma'am, you cannot steal them for anybody else. So.
So I thought,
That's awesome.
we have an IT department too.
I know.
Well, if that's everything, any questions about personnel or anything like that?
Oh, I had one more question. In terms of HR, is that separate or is it part of our regular city HR?
It's part of the regular city HR.
Okay, okay.
So we
And
are
then-
helping with the recruitment and the contract management and all that stuff.
Okay, so down the road, whatever, with disciplines, oversight, whatever, it's all linked in, it's not by itself.
Yeah.
Well, we're
And,
helping to fund it.
Yes.
and Workday is still gonna be the payroll thing, okay, thank you.
But they are funding for all the general fund expenses through this. So they are paying for those resources. The EMS fund is paying for those resources, if that makes sense.
Yeah,
So Chief, do you want to talk about like, you're funding like an HR analyst and IT?
Yeah,
person?
so we understand, what's that?
Oh, go ahead, I just couldn't remember if we were getting into funding here yet, okay.
Well, just the extra workload we know, so we are funding for an HR business partner, for a fleet technician, as well as a IT person as well. So definitely not gonna burden the rest of the city with this initiative.
Okay, do we have an AI specialist?
The IT person probably will
We
work with
get
the.
two data analytics people right here.
Yeah, I was just talking to a doctor today about how they're using things for triaging specialty. And it's fascinating, absolutely fascinating.
Yeah, in the IT department, we do have a program for AI and we have like FTEs that are specialized in it. So I'm pretty sure, that the staff will work together, kind of find those AIs.
Yeah, I think there are a lot of possibilities there.
I was just talking to AI about this meeting. No. Moving on then to ambulance and equipment update.
You want to talk to the ambulances, chief? Did I put you on the spot?
You did, but that's fine.
Okay.
We ordered 10 units as far as as part of us going into the ambulance business. 2 were already rescheduled through the bond replacement from 2022. So we received those 2 Lifeline ambulances right before Christmas. They've been in service since after the first of the year. Those are the 2 training units that are part of the training program as part of the FTEP onboarding of the new paramedics and EMTs. We have 10 ambulances purchased out of Iowa. We've had 4 of them reach Springfield where they're currently getting upfitted. So that'd be a total of 6. We're still awaiting the other 4. They're all scheduled to be in town, or at least in the state of Oregon, within May. And then hopefully up here, all prior to the start, which is June 30th. But we've been very happy with both vendors that we've used. They provided a very good quality product and a very quick timeline compared to most people that if you call right now, they're probably 1 to 2 years out. They've delivered very quickly for us.
Did you say out of Iowa?
Yes,
So that's a total of 12?
12, yeah,
Okay.
total of 12. But 10 for the actual EMS process. 2 were just a replacement of what we currently had, which were 2004 ambulance or 2003 ambulances that would get replaced.
Did we have 3 at one time?
We had 3, but we repurposed one as a tow vehicle for the boat just because we were not using them. And so, but we did have a total of 3, but we only had 2 on the replacement schedule. For
Okay.
one.
Okay, thanks, because I had that 3
No,
in my
absolutely.
head
No,
from
we
the
did have
old
3.
ones.
Yep,
Okay,
absolutely.
thank you.
Yep.
Okay, thank you.
We're currently not gonna get rid of that 3. We're gonna hold on to those just to see how the system grows. Because if we had to put them in service, they're so operable. They're just not, they're not outfitted. We don't have the equipment on them.
Sure.
But worst case scenario, if we had to put them in service, we could.
That's a good move. Thank you.
Equipment and supplies, Kyle, you want to talk about that?
Yeah, so the supplies is something that we've been constantly evaluating. The way we're gonna move forward with it, one of the industry standards is to have what's a vending type machine that has all those supplies in it. It's all automated. It helps with our inventory control. It sends us reports, it sends us messages when things are low. We will have those strategically placed in some of our stations. That'll be the most common routes for the medic units. So they'll be able to resupply quicker and more efficiently. And then with the new Hertz building, we also have a medical supply room that will be fully stocked. That we're working on putting together now with new buyers that are coming in. And that will also be, that buyer has experience in medical supply ordering from the hospital. And so he will help build that to the way that he sees fit. But we have everything in place for that. And we're just waiting for him to get here for that.
On the way out today, you can look at a couple of vending
Yeah.
machines too. There's
Yeah.
in here.
I'd like to see them. Who's going to service them or fill them? Do we do that ourselves?
That'll be the buyer's responsibility, but we'll have support staff also that will help with that. So we're just evaluating right now we have some information from the current medical provider on supply usage and stuff like that, just kind of estimating, raw estimations on what that will look like. But if we have everything in place for that, to make that happen. So
We're bringing on software called PS Tracks. The PS Tracks connects us up to the VIN machines. So whenever the VIN machine gets something taken out, if it gets to a certain point where it needs to be refilled, that software will send an email to the buyer and say, hey, you're down 18 gauge needles. You need to go to resupply machine at station 10. And so it's just a matter of using technology to our advantage. So you don't need to have the massive amount of workforce that some departments have to be able to do that.
To count, keep track of everything.
Right.
Yes.
Well,
So-
inventory control is gonna be something that's gonna be super important for us, in having one central location, with somebody responsible for that solely, that can service everything else. That'll help with our inventory control and our, forecasting on what we'll need for supplies. So.
Very good. Any other questions about that? Okay, moving on to the infrastructure update.
Wait a second. Station improvements, where are we? Fire street.
Infrastructure.
Infrastructure.
Oh, okay.
First building. I think we're on either today or tomorrow, get occupancy.
That's correct.
That is correct. Yeah.
So, yeah, it looks great. Certainly, we can facilitate a tour over there if somebody wants to, but, yeah, we're on the verge of, moving in there. Great facility, and certainly this has definitely been a collaborative process, and the city has certainly helped us out quite a bit. They've really worked hard to do that. So, that's looking great. Station improvements, well, ramp lighting, I think, is just about in everywhere, isn't it?
It's in the main stations where we're starting out deployment. They ran into some problems with the older stations. Just running wires through the older stations is complicated. But they are working through it. They will tackle the leftover stations over the next 3 months before we go live. But ramp lighting is in stations 10, 1, 5, and 3. So Am I right, Matt? No, 10, 1, 5, and 2. So, and then we will move on to the other stations, periodically, so.
What is ramp lighting?
So basically, Matt, you've experienced more than I have. You wanna talk what ramp lighting really does?
Sure. There's actually quite a few features of it. It's basically so in the middle of the night, as the lights continue to kick on with different apparatus in the station, they A, don't wake up everybody, and B, they don't just shock your system with just bright white lights and super loud tones. And so there's decreased lighting that's like a red light that actually gets brighter as the tones start. The actual voice doesn't just come on, like slam on at one volume, like all the way to volume 10. It actually ramps up, so it'll start at like 2, 4, 6, 8, so it kind of progresses to wake you up. So again, it's not supposed to shock your system because of some of the cortisol dumps in your body. It's actually supposed to be a lot healthier to get woken up that way. And then each room actually has a screen, and so you can select what apparatus you work on. And so you're only getting woken up for the calls that you're physically going on, versus everybody in the station right now. Before that, all the stations would wake up with every tone. So no matter if it was a medic unit, ladder truck, battalion chief, whatever it was, everybody got woken up for everything. Now you'll get to walk in every morning and set your volume that you like to wake up to, how bright the light you want to be, and then the unit that you're on. And that resets every morning at 7 a.m. per bedroom.
The first fire station I worked at had an air horn that woke us up, and so I think I'm probably about 10 years off my life from that. So I'm glad to see that we're evolving as a society and fire service for sure.
I did an overnight at Station 3 and I told the guys, you might have been there, I said, it's like having an infant child. Because as soon as you doze off, it screams at you. Wake up and get back on the truck.
Especially at that station.
Yeah, right. Yeah, and the voice, I assume it's automated.
Yeah, it's not,
Yeah.
it's like 3 voices.
Medic 1. Yeah, okay, awesome. What else in that? Anything else there?
We talked about the vending machines. You can see those on the way out, but we're facilitating getting those out to all the different proper locations. And then the additional beds, where are we at on those, Brandon?
We're ready to go,
done, right?
chief. Yeah, we're done. So.
Awesome. Contracts, the exciting part.
Yeah, it's been a process. So when we first started the process, we started with Kaiser Permanente and talking about interfacility transfers. We call them IFTs. And in order to kind of have a good standard idea of what we were gonna experience, we looked at the data, what they were doing, how many IFTs they were doing on a regular basis. And so we are in the process right now of negotiating their contract to handle their 450 IFTs that they do every year on a regular basis. So that helps us with manpower and what we're gonna and woman power, with what we're gonna need when it comes to aim assisted deployment and having that ability. And I know Mandy and us and our team met to talk about doing an additional contract with Salem Health, just to be able to understand what their needs are and to be able to give them what their needs are when it comes to their scheduled and unscheduled transfers. So it's a process. We haven't quite finalized the contract with Kaiser. We're working through that right now. And once we do, then we'll present the same kind of contract to Salem Health and see what we can do for them. So we're also working through, we just signed a contract with Lemon University to do their football games. And then we are gonna reach out to Bridgeway to see if there's another additional interfacility transfer contract that we can do with them.
And none of these contracts will go into place until
July 1. So, and when you do get our fee structure, you'll see that there is a set IFT transfer rate in there. So, and our goal with IFTs is when you look at what we charge for 911 costs, right? We have a set cost for 911 transfer, 911 calls. But we're contracted with Medicare, Medicaid with how much we get from them. Our goal with IFTs is to have a set rate that the organizations reimburse us for. And then if they do want to seek a payment for the patient, the goal is to have the organization seek the payment for the patient and not us. So it's a set rate, set goals for both organizations to meet.
What about Bridgeway? Can you explain that?
Yeah, when we talked to, I think Tim, when we talked to him, he's like, yeah, definitely, if there's any kind of transfers that they need from theirs to the hospital or to a care home or whatever they need, they would love to enter a contract to have a set rate versus having to pay a 911 call and basically not to bog down the 911 system. It's just, and if we can do that, it's better understanding and a better management of the 911 system versus just letting them, Bridgeway just call 911 to be able to do it.
Questions about any of that?
Okay, when I reviewed my notes from our December 5th meeting, I was trying to remember, I had something, I couldn't remember what we were talking about. I have a note that says Metro West.
Yeah, Kaiser currently contract with Metro West
Okay,
because Falk cannot they can't support it, right? IFTs, they can't support the 911 system as it is. So they struggle with that. So they have first right of refusal. So Metro West currently contract with Kaiser to assist them in doing that.
okay.
That is not our goal. Our goal is not to use Metro West at all. And that's why we're entering into contract with Kaiser.
Sure. It's just one of those things where I scribbled down part of a note, not all of it.
Yes,
Another one was added transports may need to put another car in service. And then I had this $1 million per year of 24. Does that make any sense?
Yes, ma'am.
What is
so
that?
If we are to contract with Kaiser and contract with Sam Health, right? And we would get their data and look at their data and see what their transfer rate is. If we average anywhere from 2 to 3 transfers a day, if that's what the data proves, that will help pay for an additional car in service. If we did a 12-hour car, it's around $500,000. If you did a 24-hour car, 7 days a week, it's about $1 million in cost. But the revenue that we receive from those guaranteed IFTs would pay for that extra car in service. Now, that extra car in service will not just support IFTs, though. It will support the 911 system as well. But it will give you that added personnel to be able to do those interfacility transfers, because it's not just local. They are going to Portland and Dallas and so forth. So
When you say car,
ambulance, I apologize.
no, that's okay. I'm just making sure. Plus we have some folks that haven't been involved
ma'am.
in this. Okay.
Yes, ma'am. Sorry, we talk about this so much.
I know. It's kind of like acronyms.
Yes,
Well, it
ma'am.
is. No, I appreciate it. Thank you for being patient with my questions. Okay.
Anything else on that? Moving on then to billing company update.
Okay. It's me too. Okay, so when we first started the process, our contracted provider is Systems Design Northwest. They said when we submit a chart to them, it costs us $25 per chart. If you look at our expected transports, that's roughly $500,000 in cost. Secondary to that, I looked at how their transfer information was from them to us. And it was a struggle from my office to be able to even get the minimum amount of information. Whenever I need a breakdown of what a patient owes and with who are collections, I have to send an email, and then I'm basically waiting for them to respond back to me. And so it slows down the process, slows down the things that we normally need to do. So then we started, when I went to EMS World and toured all of the different billing agencies, I come to find out, I didn't even know this, that the industry standard kind of went away from charging per chart because they charge $25 per chart regardless of what revenue they bring in. The industry standard shifted away to that, and they shifted to a percentage-based model where they charge only based on the revenue they bring in, which makes more sense to me because they're a billing company. Our goal is to bill and bring in revenue to pay for the system. And so we looked at the top producers, and when we looked at it, we come to find that EMSMC was one of the top producers in the country. And they're really, really big on the East Coast, and they're slowly coming out west. So we started looking at other companies, and they were the number one product. So we went through the process, brought them on board, and they are going to be our billing company as of July 1. So we're working on the decreasing the use of Systems Design Northwest. And then once that's done on June 30th, we will shift over to EMSMC. I know you asked a question about the Better Business Bureau, right? So one thing is right when I got your question, I reached out to Kristen, and she said, well, that's a common question, right? But they're a billing agency and a billing and a collection agency. She says the problem is them, being part of that organization, it's just a fee. They have to pay for it. And they typically, when people reach out to the Better Business Bureau, they're called to complain because our collections agency and they don't really quite understand exactly how the medical billing works when it comes to, just because you have insurance doesn't mean you're not gonna have part of a bill on a transport. And so that's part of the complaints that they get. And then in turn, I reached out to System Design and they said they weren't also a member of the Better Business Bureau. So it is a collection agency and it's just not something that they really felt they needed to be a part of. And so they look at it every year and every year their board continues to say, no, there's just no reason for it.
Okay, that
So-
makes sense. Now, let's see, the fee, their fee is 3.1%. Is that
That's correct,
still
yeah.
true? And how long is the contract?
For 5 years, ma'am. But there is a gradual, there could be there's a thing where they could increase the fee, but it's all controlled by the contract.
And then you mentioned with the revenue they bring in, so what is considered revenue? Are there things that we take in that they don't deal with that wouldn't be subject to that 3.1% fee?
Collections, if we had to send it to a collection agency and they couldn't collect any money, the collection agency says it does a set fee. Beyond that, but they actually bill the patient. If you were to go to a collection, it would leave EMSMC, go to the
Right.
collection agency. The collection agency would bill a fee, but nothing on the revenue that they bring in. It's an additional fee on top of what they bring in. So
Okay, so everything, they're basically gonna get 3.1% of all our revenue,
outside the collections, yes, outside of going to collections.
but it goes to collections.
We use a company called PCS, and that's a standard practice for the city entire as a whole. So
And, okay, well, that makes, so it doesn't, I was thinking, because the revenue I thought came in and then stuff that could not be reimbursed or whatever, then would go to collections, but that's
So,
not how it works.
let me give you an example. If I billed you the $2,509 for your transport, right? And then you didn't pay any of your bill. And then it takes about 6 to 9 months for that bill not to go to, not for you. They will ask and ask and ask, and then you finally don't pay any of it.
Right,
Then it leaves System Design, EMSMC. It goes to PCS.
okay,
We don't pay EMSMC for that $2,509 that they billed.
okay,
Now it goes to the collection agency. Whatever the collection agency collects, let's say they collect $100 from you and then write the rest of it off. They'll collect $115 from you because the $15 will be a fee. The $100 still goes to us.
okay. Okay, that makes sense. I'm thinking of it both as actual cost plus what we're using for forecasting, et cetera, just kind of thinking about a bunch of it, so thank you.
The only money EMSMC brings, the only money EMSMC collects is if the money that they actually bring in. So if they bring in $1,000, they collect 3.1% from that $1,000.
Okay, and that's also the revenue, like if we get any GEMT reimbursements, that's not
That's
considered
separate.
revenue?
That's separate revenue. That's not money that they're billing. That's managed by the state.
Right,
Oregon Health Authority,
Yeah.
yeah.
Yeah, okay, but that's revenue that isn't impacted by the fee.
That is not impacted by the EMSMC.
Okay, all right, I just.
And for instance, we also bring in fees for firemen. Each individual who is a member of firemen pays $70. That $70 is not impacted by EMSMC.
Okay, that makes sense. Reimbursements. Okay, not. Getting through my questions, I appreciate this very, very much. Oh, one more thing on them, on the collection processing, one of the things that was mentioned in the Triton report was how cities are different in terms of how aggressive they are in their collections.
Yes, ma'am.
So where does EMSMC kind of fall in that? Because it talked about a little bit about political, some of the impacts of that. And I was just wondering kind of generally how they fall.
Well, they're gonna do their due diligence to see if to get everything they can, not everything they can, actually, that's not the right terminology, but they're gonna do their due diligence to be able to bill the patient and ask for the patient to pay, correct? So, but after a certain amount of time, again, we're still working through the parameters of their timeline. After a certain amount of time, once the patient hasn't paid, it's gonna go to collections. We use PCS, which is the current contractor of record with the city. And the city, after 6 to 9 months of PCS not being able to collect, they are gonna take them to court and they are gonna sue them to be able to pay. So, and again, that's standard practice in the city right now for utilities and so forth. So, that's the process. It's not where we don't impact their credit. So we don't, and legally we can't. And so it's just a matter of step by step going through the process. But we do have ways for people to be able to ask for hardship. So we have those processes in place and we're working through a process to be able to apply that hardship if they request it evenly across the board for whoever asked for it. So we're still working through that now.
ESMC also has, they have a very thorough collection process so that a very, very small percent that does not get collected, very rarely even gets collected on collections because they've done such a thorough job. So.
Yeah. For instance, if you are transported in an ambulance right now and you don't sign the bill, sign the chart, theoretically, we can't bill you. So our goal with the EMSMC is we can see the analytics in the back office portion to make sure that, and we see within 24 hours of that billing to be able to see if there's been a missed signature. So our goal is to be able to not have that happen and not have that occur, to be able to have 100% billing. Because that's lost revenue, and then that impacts the system as a whole.
That takes care of it. I did have something about signatures and stuff, but it was obviously something different. Okay.
And I mean, I'd love to, once EMSMC gets up and running, I'd love to show you the back office portion and just how their analytics work. It's pretty impressive. They're the #1 leading company in the industry that does that. So.
Chief, did you say that you had experience with that company?
So the largest company in California just merged with EMSMC. So they're working together. And so their processes are very well aligned. And so very familiar with the company that they merged with. And when they merged, we had several presentations on how that was going to be affected. And then during the merger, I was still there for a few months and it was seamless and they did a great job.
You know, the System Design Northwest, we tried to bring credit cards to, because a lot of your health savings accounts give you a credit card to be able to pay your bill. We didn't allow it for the longest time. It took 18 months to get System Design Northwest online to be able to allow people to pay with their credit card. It took EMSMC 30 days. So that's just the difference of those kind of concepts. So Jen, the CEO of System Design Northwest, is a smart, driven CEO, and she's been great to work with, but it just, we're getting bigger. And as we get bigger and we bring on this, we needed a company that can handle that kind of call volume and that turnaround time. It takes us almost 45 days to do billing. When we transport them first, we don't bill, and Darren can attest this, we don't bill. It takes a while to get the revenue. MSNC is a 24-hour turnaround, so.
Be interesting to see what that does.
Yeah.
Anything else?
Not on that yet. No, we'll be hitting on some other stuff. So that's it for now.
Okay. Moving on then to whole blood storage and critical care paramedics.
So the whole blood, Dr. Coder and I reached that conversation briefly last few months. And I think we sat in a meeting, was it from the hospital? Somebody from the hospital, that talked about that. It is something that we're looking at, but at the moment, we're gonna get our feet under us with this program, get established, and it might be something that we look at in the near future to medium near future. There's some logistical problems with it that we have to work through. I think the blood has to get changed out every 10 days or something like that from the medic unit. And so we want to be thoughtful and conscientious about what we're doing and be ready to do something like that. So it's on the radar, but it's not on our immediate radar.
I think it's just one example of many different treatment improvements that we're looking at.
And the same goes with the critical care paramedics. I mean, that's something that Dr. Clothier and I will be talking about in the future, as well as pumps that we'll be putting on the medic units. So all those things take some time to build and prepare for and have infrastructure for. So we want, like I said, we're gonna do something like that. We want it to be meaningful and we want it to be effective. So, but we certainly have to get the program established and our feet under us before we jump too far into the deep end. So,
Did you say pumps?
yeah,
What is that?
pumps on the carry the pumps, blood pumps for the medic units. And meds and medications, they don't currently have that. Some years ago, when certain people in this room, myself, were on the medic unit, you would take a pump with you and a nurse maybe when you go to Portland or something like that. So some agencies use them quite a bit, but they're kind of expensive and they take a little bit some more extra training and stuff like that. So it's not too far off the radar, but it's just another thing that we work towards.
The critical care paramedic side, contractually, Kaiser's asked for that in their contract. And it won't be right away because we don't have them, but our goal is to have critical care paramedics that can transport those critical patients up to OHSU and so forth. So.
Would that be additional people or is that just a training certification?
Certification, training and certification.
And it would benefit the hospital. We could work closer with the hospital on some of those critical transports, life flights. Sometimes when they can't transport up, they will typically have their personnel ride in the medic unit. But they have more critical patients if the weather's bad or if the patient has a weight restriction or something like that. So we're talking to them about stuff like that.
But that would pull paramedics out of our new system.
Well, IFTs will too, you know, and inter-facility transfer, that's the reason why it's a contractual obligation, and that's the reason why we talked about adding that ninth car if the numbers did present themselves correctly. So, yes.
Concept between the IFTs is so that we're better prepared for, if we have calls that you are ready for, that you know are coming, and we can statistically predict them, and we have the infrastructure to prepare from that would be the better business model. So it wouldn't take from the 911 system
Okay.
or have less impact.
That makes sense.
Anything else on that?
No.
Okay. We've touched on GEMT a little bit, I think, right?
We did.
But what more would you like to add?
I know that Councilor Varney had asked a question about the federal government side, what the federal government was doing on the Medicare, Medicaid. At this point, I don't think any of us know about what they're doing. We've looked at the system between myself and Ryan Zink, what GMT is supposed to or predicted to provide in 2026. We've also looked at it if they don't provide the funds in 2026, and overall the system still is viable and profitable. I hate to use that word because it's not a profit driven organization, but it's still at the end of the day is supposed to be have funds left over at the end of the year, even without GMT. Now, are we hoping for that? No. GMT looks like it's hopefully continued to move forward. And last I heard, they were still fighting over Medicare, Medicaid and what they're going to do at the federal level. So I don't have a crystal ball, so I can't tell you which way they're going to go.
But we could still operate without it.
You are correct.
It's just you're gonna have it small enough.
Yes,
There's been
ma'am.
several agencies in the last couple of months that have joined on to GMT even in the last couple of weeks too, so it's still moving forward.
Yep.
Could you go into a little more detail on how the GEMT reimbursements work and how, like, the fee system to reimburse OHA for the cost of administering the program?
Yes, ma'am.
Okay, we have new people too.
Yes, ma'am.
Okay,
So,
thank you.
ground emergency medical transport, right? So there's two different methods for us to collect revenue from that. So one is for where we contract with critical care organizations. Sorry, not critical care. They're called CCOs. I forget what CCO means. The coordinated care, thank you. so we contract with those organizations and it goes through the Oregon Health Authority. And so that's the biggest portion of GMT right now is, that funding. And so that's all done through billing. So now it's all kind of gleaned off of our billing, our EMSMC, right? So it just kind of funnels through them to the state. They track it, right, through Medicaid dollars, and then we are reimbursed based on those transports. So, and then the other part is fee for service. Now, the fee for service is a lot more detail oriented and a lot more work to put together. And but it's a very small portion of the total GMT dollars that we will bring in. So you talked about the costs. So right now they're, in order to participate in GMT, the state through the Oregon Health Authority sends us a bill twice a year for those fees. We pay 20%. So we get a large fee. Let's say the fee is $500,000. The state will charge us at 20% of that $500,000 to basically operate or participate in the program. So on top of that $500,000, we're going to pay another $100,000 for that fee. So we get a bill for, again, I'm just using that number for an example, $600,000, and we will pay that. And then the state sends us, tells us what the amount that we're going to get from the CCOs. So it should be more than that. So we don't know that amount though until after you pay the fee.
There should ideally be a fee reduction since we're going to be one of the larger agencies that's going to be doing many transports. And so with that offsetting cost, hopefully it should reduce the fees for everybody.
Yes, that's the goal. And I know the Oregon State Fire Chiefs Association has been working really, really hard with OHA and the team that manages the GMT to reduce those fees. So our fees are, I think, unusually high. So.
Yeah, I need a flow chart, a diagram to understand how it all works.
Yeah,
It is very confusing.
I estimated the GMT, the fees this next year, and you'll see it, the budget is roughly $900,000. The fee.
The fee itself,
Mhm.
okay,
And you'll see the budget that's coming out, so.
yeah.
Yeah, but the revenue, again, based on experience, should far exceed that. So,
Okay, I mean, I'm anticipating questions I imagine like the finance committee might be asking too about how this is all going to work. And of course, like you said, you don't know about
Well,
reimbursements for sure.
but it's currently working now.
Uh-huh.
So, and it's currently operating as defined. It's operated for the last, I mean, we've used GMT since we've been transporting, and we've had the fees, and we've always collected way more revenue than we paid out. So, if I remember right, last year, I think we paid $90,000 and we brought in just under 400. So usually the fee is about 25% of the overall what you're gonna bring in revenue. So again, I don't have a crystal ball, so I can't tell you exactly what it's going to be, but I do believe based on what our estimates are and based on past experience, the data tells us that that's exactly what it's gonna be. So if we pay $900,000 in fees, you can probably estimate what we bring in revenue.
Okay. I guess before we move on, I didn't know if I was gonna do this at roundtable, but speaking of fees, one of the things that as I was reading through the Triton report again, I was wondering, it was completed using data when we were in the middle of COVID. A lot of the stuff was 2022, for example, and so I was curious about the changes in response times and the incident breakdown versus what they have in the report, because things were different then, and just wondering how that impacts this whole process, just kind of an overview. Are there some distinct changes between, like I said, the incident breakdown or other things where that might have?
They didn't just use COVID data though, ma'am. They used 5 years of historical data. So that 5 years of historical data, I mean, they gave them a clear picture. And the only year that we had a weird anomaly was in 2021, when we had a massive uptick in call volume. And so even if you took that 1 year away, we stayed at that call volume. and we've continued to grow. I think this year, Chief, am I correct, 6.2% in the call volume? And right now, Falk is reporting that they're running, again, Darren, correct me, around 60 transports a day on the average. So everything that we're doing supports the process and what we're doing in the deployment. Right now, Falk currently is contracted to do 1,030 hours. And so far, we built a system to have 1,080 hours. And again, if we contractually do the IFTs, we'd like to increase that even more and add more hours in. So we have the personnel to be able to man those medic units on the schedule that we've already defined. And so I think we're going down the right path to be able to deploy correctly and efficiently.
Okay. What percentage of our calls are EMS calls these days?
73%.
Okay, so that part hasn't changed that much. And how about fire?
Look. 6% or something like that. Have to look.
Okay, because in here, I was just wondering, because that's gone up, it was 2.5% in that, okay. Just comparing to, last couple of years, out of curiosity. Okay, thanks.
I have a question. It might be going a little bit backwards, but just curious if anything's been figured out about possibly billing folks for an ambulance call. If they have an accident, nobody gets a bill for that.
The insurance funds?
The fee for service.
Fee for service.
Are you talking about, you're not talking about medical calls then? Are you talking about outside of that, like
Yeah.
car accidents, that
Yep.
type of thing? So we had a discussion about it. There are some legal considerations for that. There's many states have actually banned that, but we are looking at it. It does, for us to actually initiate that, we need a software program that's gonna be about $50,000. We need a record management system. So certainly within the economy that we're in right now, after the next fiscal year, we do need that either way. So if we put a software program into place, then we have to have IT needs to evaluate that before we can initiate it. There's training that's involved with that. So if we did move forward in it, we're probably looking at late summer to early fall.
Thank you.
And we take it where it is from the council to be able to do that.
Okay.
Yeah, we're definitely good.
Did you have something else, Councilor Ryan?
No, I was just, your question, just, emergency medical service. Is just reminded me of a couple of things in this thing on funding alternatives for EMS services, basically. Okay.
All right, on to deployment.
You want to talk about like our medical, the ambulances, how we're deploying them or the plan is?
I didn't create the
It's just
agenda.
deployment, just how we're.
Yeah, where they're gonna be.
So the current plan is we're gonna have 5 24-hour medic units that will be placed in strategically in the city. And then we will have we call it a surge car, our peak hour car, which is a car as medic unit. That is an ALS peak hour medic unit that will run 40 hours a week. And then there'll be 2 BLS units that have the same deployment of 40 hours a week. So we'll have 8 medic units running in the city, 5 of them 24 hours, 3 of them 12 hours.
What's the ALS and BLS?
Advanced life support and basic life support,
Okay,
sorry.
thank you. No,
Yeah.
that's okay.
Could you run through those numbers again one more time? I'm sorry.
Yeah.
I don't write very fast.
So we'll have 5 24-hour medic units, ALS medic units, advanced life support medic units. We'll have 1 40-hour a week peak hour medic unit, advanced life support, and 2 basic life support peak hour medic units.
So that's 8, okay. But like 24-hour, that's only 5, and then that'd be an 8-hour shift, and the BLS or the 2 BLS are what shift?
They're peak hour as well, they're 40-hour a week. So 1 ALS, 2 BLS surge cars that run 40 hours a week, 7 days a week.
And the goal is to deploy them 10 to 12 hours a day, 7 days a week.
And so what was this based on? Out of curiosity, how did you come up with these?
We look at a heat map and and with the call volumes going on, and we look at where, kind of like that, yes, ma'am, but it's more of a graph, right?
Yeah.
And we're data driven.
Mhm.
And so that's how we looked at when our most calls happen. At night, they happen,
Sure.
but just not as many during the night. So you don't need 8 24-hour cars. So, and remember, a 24-hour car is $1 million per car, right? So to be able to man that 4 days a week, 7 days a week, 24 hours a day. So we realized that we didn't need to do that. We realized that it's better to deploy 24-hour cars and day cars. And on top of that, you also have employees that actually don't want to work 24 hours, that also want to be on at the work-life balance. And so it's better to offer alternative schedules, so they just don't do 24-hour shifts. So it was kind of a, you're covering all your bases. So.
Okay.
The only other addition to that is if, as we look forward to the IFTs and we establish some of those contracts, we may put another unit in service to cover some of those calls, which would sustain itself through the IFT contracts.
I think not only is it an efficient way to do business at your peak hours, but it does offer a lot to a workforce where you may have parents that don't want to be gone for 24 hours. It definitely lends itself to having a diverse workforce for sure.
Which we're seeing the fruit of our labors in showing that.
See, I have a note here, regarding the call system, their new CAT system, is that what that is?
CAD,
CAD
CAD.
system, yeah. There was a discussion, I think, at the last minute about that, because we were talking about triaging, lower acuity calls, response time goals, and I just didn't know if there were any updates, anything.
We just started a triage committee, so we are looking holistically at our triage system and sending the right resources to the right place at the right time and the most efficient way to do that. And so we just seeded that, and we're looking at our data as well as other systems and how they're best working.
Counselor Varney, one thing I will say about, we're data driven. So those two individuals that we're bringing on here are going to help look at the data and be able to make sure we're deploying correctly, right? So this is the first time I've set up a brand new EMS system. It doesn't happen every day. And so bringing those two individuals on, very smart, very driven individuals, they'll be able to help kind of pinpoint if we are needing to change, they will be able to help give us that data and be able to do that. We're also bringing on a thing called Dark Horse. And Dark Horse is a live system that looks at our last 5 years of data, and it looks at how we're deploying, and it gives us an idea within 24-hour updates of what we're doing and how we're doing it. And if we're doing it right, if we're doing it wrong, we need to change. So.
Oh, that's impressive. I appreciate that. I think everybody appreciates that, staying on top of it and changes.
We're definitely evolving. I think we're a little behind on their data analytics, but we're going to be right at the forefront come July 1st. So feeling good about where we're at. 100%.
Exciting.
And is it Emily? Yes, she did 5 years of data in 2 years. So I think we're gonna be
Less than 2 years, yeah. That's for sure, that's for sure. So is there a particular application that you work with and that are the reports that come out of it? Can you adjust them or whatever?
Well, this is my first day in this position, so as far as how the reports are coming specifically, I'm still learning that. However, in my experience, when I'm able to retrieve that data, typically I'm able to utilize it in other systems if I need to, so that I can make adjustments to analyze it, if that's what you're looking for.
Kind of, as long as you can get it. I know, for
Correct,
example,
yes.
Workday is really hard to get information out of. And I know that you're not gonna be dealing with Workday.
But yes, once
But
we get
I'm
the-
thinking other applications where I've worked with stuff a lot because I'm a data analyst as well, and having to pull stuff out and get it to mesh with
Somewhere
the
else,
other
miserable.
ones when you're working with 3 or 4 different databases. It's nice to have that flexibility. So
Certainly, yes.
appreciate that.
Something
Thanks.
that definitely we're looking into, and as we're learning, we'll know more, so yes.
Yeah, well,
So if I may, sorry, so I think there are quite a few options at this point, so we can, we have the VI publisher.
RBI.
With the Power BI, and then we also have like solutions that we are trying to bring through, like the AI solutions. And so I think there is an opportunity here to analyze what is the right tool to use, so definitely.
The beauty of it is we've had a gentleman that we work with he's been at the city for over 20 years, and he grabs raw data and then analyzes it.
Mhm.
These 2 individuals will be able to grab raw data and analyze it to the nth degree. One thing that they had to do in order to get the job is we gave them 40,000 lines of data, Darren?
400,000 lines.
400,000 lines of data, and they had to present it to us and analyze it, and they'd never worked in EMS at all.
Mhm.
And, so they did that, and they did that very well.
So you're just making a case for me to steal that.
Yeah. So that's the beauty of it. I mean, again, it's impressive to watch, and it's gonna be impressive to see firsthand, so.
yeah, no, that's good. I'm used to working with the 250 to lots of lines of data.
Yeah, it's gonna be fun.
Yeah, and pulling stuff out. Yeah, it's gonna be a lot of fun. I'm just gonna have to come look over your shoulder sometimes. Cause I'm kind of a data nerd. It's kind of fun. It's like puzzles.
It is.
It is. And the picture that evolves from it. Yeah, that's what's so exciting. Okay.
Anything more on that? I know this is a rectangle, but it says round table.
Use your imagination.
Yeah, I assume that means freeform.
Yes, ma'am.
Anybody want to talk about anything?
Well, I think we are, and I know Chief Correa just mentioned it's the first time you set up an EMS system, but the amount of work that's going into it is admirable. It's been nonstop. One of the things we did last week was we actually met with another agency that started an ambulance service, public ambulance service 3 years ago. Same size, same call volume, and I think what it did is validate a lot of what we're doing, and so I felt really good about that. So we're certainly looking at other systems, looking at the best way that we can deploy our models, and we know it's going to be evolving. I mean, that's why part of the data analytics is it's not going to be static. It's going to be constantly improving. And so I think we have all the pieces to make sure that we have the best system possible.
So Chief, if I may, as we were kind of talking about the EMS deployment, the piece that I'm excited about is the business model that we have on this is, it is going to be a self-sufficient program, right? And no reliance on the general fund resources, and to be able to kind of look into the program and serve the community better, but at the same time, a business model that is sustainable, right? So I appreciate the work that you and the team have done to kind of, I know there are so many pieces here. It's pretty complex. And so Brian, I know you have been leading this, and also thank you for your work on this.
Yeah, I think the benefit too is when we have, whatever revenue comes in, we don't have any excess revenue going to shareholders, right? Or to private, it goes reinvest in the system to benefit this community. And so it is system enhancements and improved service.
And that's kind of the bottom line, a better service to the community.
Absolutely. And revenue neutral. I'm very well.
You should have for that.
Hospital offload update. How are things going?
I mean, from mine.
Time wise, I'm just kind of curious. That was just something.
Why not?
I mean, I think Salem Health is doing a great job.
So curious because another thing that came up before that I had a note about to check on it. Okay.
I'll speak to it a little bit with Mandy's permission.
Sorry to put you on the spot.
So by offloading, I assume that you're talking about wait times at the hospital. So we have had an improvement over the last year, I believe, overall. You know, the hospital is not, fully responsible when the system just gets slammed and,
Sure.
70 people walk through the front door and 10 ambulances show up. There's always room for improvement, and the times that we've had ambulances backed up down there, when Mandy is there, it's very easy to go down and talk to her and get a plan together and get that going. Like I said, we're always working to improve it. Work with the IFTs, I think will be beneficial. We're planning on partnering more with the hospital come July and preparing for that beforehand. So I think overall they're better. I haven't pulled any stats or data analytics, but sure can now. I'd say that's a fair representation from my perspective. But I also don't hear about it every single day. Sometimes they are longer waits than normal. But from your perspective, I don't know what you say.
Yeah, I mean, we see, or we receive anywhere from like 100 to 120 EMS a day. So that's a third of our volume about. And so, like Kyle said, I mean, sometimes 15 of those come at the same time, and then 30 patients walked in the front door. And so just managing both of those.
Sure.
But I mean, there are surge times during the day, and we do our best to offload as quickly as possible, and always want to get that back into the community as quickly as possible.
Okay.
Yeah.
No, I really appreciate that, because that's why it came up, is when you have, obviously, it's out of service.
Yeah.
It becomes more of a problem. So that's great to hear, especially just working together on that, especially for those really busy peak times.
Yeah, and I think we've gained a lot of ground over this last year, of the importance of that and the impact that it has on EMS when medic units are stacked up there with the biggest hospital, the only hospital in the area. So it feels like there's a little more realization about that maybe. So it's helpful. It's not perfect, but we're getting there.
Sure. Well, it is such a big undertaking, and I have just been so impressed with pulling all the pieces together the way you have. And I know I have a lot of questions, and they're not to, point fingers at you. It's where I have a better understanding of just how the whole system's kind of coming together and working, so that I can spread that confidence to others when they're curious. So I just appreciate your time, really, not only working on this, but being willing to, spend this time like today to provide the information.
Appreciate the engagement.
Thank you. So do we want to meet again before July 1st?
Yeah, can we put a date on now?
Yeah, that would be great.
Yeah, June's gonna be super busy. If we can do maybe like the second week or something, does that sound reasonable? Like the week of the 9th?
I was gonna take vacation the entire month of June. Chief.
No, I thought you were doing that July 1st.
July 1st, I'm out.
I would never do that, but I'll go mid-June to mid-July.
Are you looking at this time of day?
And whatever works for you folks, man.
This time of day works well for me.
9th at 4 o'clock.
We have council
We have
meeting.
council.
Okay, council,
Maybe 10th or 11th.
11th looks good.
11th looks good for me if it works for others.
I can do that. 4 o'clock.
Sure.
Right here.
I'll have Tammy, I'll just send her a message.
Oh, beautiful.
Perfect.
Thank you. That's safer.
Easy. It's a lot safer for me too. June, what day again?
11.
Wednesday, June 11th.
All right, is that everything then? If so, We're adjourned.
Thank you so much. Feed everybody equally here, put everybody on the spot.
Yeah.